Welcome back. In this section, we'll be discussing electrocardiography in more detail and discussing different types of arrhythmias. In this section, Electrocardiography II, we will continue to discuss some of the topics we discussed in the last section. Certain cardiac diseases are easily diagnosed using electrocardiogram. These include atrial hypertrophy, ventricular hypertrophy, ischemia, and myocardial infarction. Axis deviation, such as left axis deviation and right axis deviation, are easily diagnosed on an EKG. In general, axis deviations are caused by enlargement of the ventricles, increased mass. This is usually caused by increased pressure or volume in those ventricles and are commonly seen in right heart failure or left heart failure. You can quickly diagnose left axis deviation by looking at a positive QRS complex in lead 1 and a negative QRS complex in lead AVF. A right axis deviation will give you a negative QRS complex in lead 1 and a positive QRS complex in lead AVF. In a normal mean electrical axis, you have a positive QRS in both lead 1 and AVF. This is outlined in this diagram here. At the top of the screen, you can see a normal QRS complex in lead 1 and a normal QRS complex in lead AVF. In patient B with right axis deviation, the QRS complex is negative in lead 1 and positive in AVF. In patient C with left axis deviation, you can see a positive QRS complex in 1 and a negative QRS complex in AVF. Myocardial ischemia is one of the major reasons that we do electrocardiography. Myocardial ischemia is a temporary disruption in cardiac blood flow. The symptoms of ischemia are initiated usually by exercise or stress. Patients with ischemia may have pain called angina, which is relieved with rest. There is a reduced cell membrane potential with the current flow from the normal to the affected regions that we can see on EKGs. This is normally manifested as an ST depression, so sometimes we can see ST elevations. During ischemia, T-wave inversion may also occur because repolarization is also affected during myocardial ischemia. During a cardiac stress test, a person will be at rest on a treadmill and then start running. When the person is exercising and the heart rate increases, you may see ST depressions, as you see here on this rhythm strip. ST depressions are indicators of myocardial ischemia, or blockage of coronary arteries to the myocardium. A myocardial infarction can also be diagnosed from an electrocardiogram. During myocardial infarctions, blood flow has been obstructed to a degree where it causes death of the myocardial cells. Myocardial infarction can have similar symptoms to that of myocardial ischemia, though the pain lasts longer, is not always related to exercise, and is often not relieved with rest once the tissue has infarcted. On an EKG, what you may see are Q waves, large Q waves at infarcted areas. The ST segment may also change. You may see ST elevations at infarcted areas, or ST depressions, as well as T-wave inversions. This is an electrocardiogram that shows myocardial infarction. What you see in this EKG are Q waves in leads 2, 3, and AVF. Leads 2 and 3 are in the bottom left-hand corner of the screen, and AVF is also in the bottom left-hand corner. These are known as the inferior leads. Therefore, we can diagnose this patient with an old inferior myocardial infarction. Q waves are generally only seen after a myocardial infarction is established. During an acute myocardial infarction, a patient will generally have ST elevations as well in the leads where there is a Q wave. This patient also has Q waves in lead V5 and V6, though those are less important as the Q waves in leads 2, 3, and AVF, because those Q waves take up a significant amount of the QRS complex. ST elevations, seen here in leads V1 and V2 indicate an acute myocardial infarction or a myocardial infarction that is rapidly occurring. The ST segment elevations in this patient appear to be in the septal leads V1 and V2. We would diagnose this patient with a septal myocardial infarction. This patient also has Q waves in leads V1 and V2, as well as leads V3. These large Q waves would indicate that the patient already has infarcted or dead myocardium. Normal cardiac rhythm or normal sinus rhythm occurs in the following way. The origin of normal sinus rhythm occurs at the sinoatrial node. This causes atrial depolarization. A P wave is generally seen before a QRS complex, and an upright T wave occurs after that. The P to P intervals are usually regular, and the R to R intervals are generally regular as well. The P to R and the Q to T intervals are also normal. Any change in this may be an indicator that there is something wrong with the cardiac signaling in the heart. Abnormal rhythms may initiate at many different parts of the heart. SA nodal-derived arrhythmias such as sinus bradycardia, sinus tachycardia, and sinus arrhythmia occur at the SA node. Atrial arrhythmias, which can occur throughout the atria, may lead to premature atrial beats, atrial tachycardia, atrial flutter, atrial fibrillation, or wandering atrial pacemaker. AV nodal reentrant arrhythmias, such as SVT, which includes AV nodal reentrant tachycardias, or AV reentrant tachycardias. Ventricular arrhythmias include premature ventricular beats, ventricular tachycardia, also known as VTAC, ventricular flutter or ventricular fibrillation, also known as VFib, or torsade de pointe, which is a type of ventricular tachycardia, originate in the ventricle. Junctional-derived arrhythmias, such as nodal rhythms, which include idioventricular rhythms, junctional arrhythmias, and junctional escape beats, are derived from the AV junction. Other arrhythmias which occur because of heart block between the SA node and the AV node include first, second degree, and third degree AV heart block, which we've already discussed. SA nodal arrhythmias include sinus arrhythmia. Sinus arrhythmia is not considered a pathologic arrhythmia. It's commonly seen in patients that are young and patients with healthy hearts. During inspiration, the P to P interval or the R to R interval increases, and during expiration, the heart rate decreases. This is not a worrisome rhythm. Sinus tachycardia is very commonly seen. This is seen in patients that have a heart rate that is sinus because they have a P wave before every QRS complex and they have normal intervals, but the heart rate is greater than 100 beats per minute. Causes of sinus tachycardia include fever, pain, hyperthyroidism, low blood pressure, anxiety, and also exercise can lead to sinus tachycardia. Sinus tachycardia may also occur during myocardial infarction, during which time you would probably also see ST elevations and/or Q waves. Sinus bradycardia is a sinus rhythm with a heart rate less than 60 beats per minute. Many people at rest have a heart rate less than 60 beats per minute, especially trained athletes. Sinus bradycardia may also be worrisome in patients that have sinoatrial node dysfunction, such as coronary disease leading to the sinoatrial node. Certain medications can cause sinus bradycardia, such as beta blockers and certain calcium channel blockers. And drug overdose of medications such as sedatives and opiates may also cause sinus bradycardia. Atrial arrhythmias may also occur. One example is a premature atrial contraction. The arrow in this diagram is pointing towards a premature atrial contraction. In this rhythm, an ectopic atrial site depolarizes just for one beat in an early fashion. That premature P wave will occur, causing a normal QRS and T wave. These are commonly seen in patients. Patients will often feel the beat after the premature atrial contraction, not the actual premature beat. The beat after the premature atrial contraction will often carry more blood with it than the previous beat. That's why they feel it. Getting into the more worrisome arrhythmias, we have atrial tachycardia. Atrial tachycardia is similar to sinus tachycardia. However, it is not the sinus node that initiates atrial tachycardia. An abnormal pacemaker cell in the atrium, such as a myocardial cell that is ischemic or abnormal, will generate the atrial tachycardia. And because this abnormal cell does not rely on calcium for its upstroke, it's able to move very quickly and create a very fast heart rate. These atrial tachycardias can generate tachycardias with a heart rate of greater than 150 to 200 beats per minute. Drugs such as caffeine, nicotine, alcohol, as well as anxiety can cause atrial tachycardia. These are commonly seen after surgery as well. The treatment for atrial tachycardia usually involves beta blockers and calcium channel blockers to slow down that abnormal cell in the atrium. Atrial flutter is another worrisome rhythm coming from the atrium. Atrial flutter involves a sawtooth baseline pattern that you can see classically on an EKG. The atrial rate during atrial flutter is generally between 250 to 300 beats per minute. Atrial flutter is caused by a circular reentrant rhythm that occurs around the tricuspid valve in most cases. Because the rhythm is so fast in the atrium, the AV node is unable to transmit all of the impulses it receives. Usually what you see is a ratio of flutter waves to QRS complexes, usually around 2 to 1 or 3 to 1. The causes of atrial flutter usually involve coronary disease, valvular disease, or pulmonary disease. You should be able to recognize atrial flutter on an electrocardiogram. It's very commonly tested, and usually the flutter waves occur at an interval of 200 milliseconds. And as you can see, these flutter waves are approximately one large EKG box across, and one large EKG box across is 200 milliseconds. If the flutter waves are closer together than that, it is most likely atrial fibrillation. Atrial fibrillation is an irregular rapid atrial rate. There is no actual atrial contraction that occurs with AFib. The atrial rate can be from 350 to 600 beats per minute. There are multiple foci of depolarization. There is no actual contraction of the atrium. The ventricular rate does not correlate with the atrial rate. Usually the ventricular rate is irregular. Anytime you have an irregular ventricular rate, meaning there is no pattern to the irregularity of the ventricular contraction, you should think atrial fibrillation. People with atrial fibrillation generally have a reduced cardiac output because they're not receiving the atrial kick at the end of diastole to fill the left ventricle. The most common causes of atrial fibrillation include simply aging. The elderly are very likely to have atrial fibrillation. This is one of the most common arrhythmias. Atrial enlargement from any cause, such as heart failure or valvular disease. Also, long-standing hypertension may also cause atrial enlargement, which can cause atrial fibrillation. Atrial fibrillation is usually caused by a damaged atrium, where the cells are stretched and they become irritable. Also, conditions where a person is exposed to a great deal of epinephrine, such as stress, and cocaine use may also initiate atrial fibrillation. The problem with atrial fibrillation is that it may cause ventricular tachycardias, known as rapid ventricular response. Also in the atrium, because blood is not moving, it's possible to form blood clots in the atrium. Therefore, we worry about thrombus development resulting in systemic emboli and strokes in patients with atrial fibrillation. Here's an example of atrial fibrillation. What gives this away is that the QRS complexes are so irregular. They don't form a normal pattern. You also don't see P waves in this strip, and you see sort of a jagged pattern to the baseline. The R-to-R intervals generally are irregularly irregular with no pattern. The QRS complexes and the T waves usually are normal. The ventricular rate can be either normal or rapid. If the ventricular rate is rapid, it must be addressed because the ventricular rate can cause the heart to tire out quickly and cause heart attack. Generally, we use digoxin, beta blockers, or a non-dihydropyridine calcium channel blocker, such as verapamil or diltiazem, to slow down the atrioventricular node. This causes a decrease in the ventricular response rate. Once you have the rate controlled, you should think about rhythm control. If you're not sure when the person went into atrial fibrillation, you have to be concerned about blood clots in the atrium. These patients, before they are converted back to sinus, need to be anticoagulated, usually for 3 to 6 months. You can also consider doing a transesophageal echocardiogram to look for a blood clot in the left atrium, which is usually where they form in patients with atrial fibrillation. Once you're certain that a patient does not have a blood clot or they've been anticoagulated for an appropriate amount of time, you can cardiovert that person, either pharmacologically, usually we use amiodarone or another antiarrhythmic drug, or through a direct current electrical cardioversion. The person will then return to sinus rhythm in most cases. Atrial tachycardia, here's another example of that as we saw before. The P wave is usually abnormal shaped and the PR interval is generally short. In this 12-lead EKG, you can barely see the P wave because it's almost buried within the QRS complex. Some more atrial arrhythmias, including wandering atrial pacemaker. In this top strip, you can see that the P wave changes morphology from QRS complex to QRS complex. When the heart rate is normal but you see multiply shaped P waves, you should think about wandering atrial pacemaker. In wandering atrial pacemaker, the sinoatrial node may contribute to sinus rhythm, but there are other atrial myocytes that are also generating P waves. Multifocal atrial tachycardia is similar to wandering atrial pacemaker, but the overall heart rate is faster. It's very simple to confuse multifocal atrial tachycardia with atrial fibrillation. They often look quite similar. You should be able to recognize a wandering atrial pacemaker on step 1 of the boards. Ventricular arrhythmias generally are more worrisome than atrial arrhythmias. Ventricular arrhythmias are often associated with instability. Ventricular arrhythmias arise from within the myocardium of the ventricle. Because they generate a QRS complex that doesn't travel down the normal His-Purkinje system, that QRS complex is usually abnormally shaped. It's usually wide and has a varying morphology. Ventricular arrhythmias include PVCs, or premature ventricular contractions, ventricular tachycardia, ventricular fibrillation, and torsade de pointe, which is a type of ventricular tachycardia. PVCs, or premature ventricular contractions, can often be benign. They may also indicate underlying disease in some patients. A premature ventricular contraction is a QRS complex that is prolonged, usually greater than 0.1 seconds. It has an abnormal morphology and does not usually have a P wave before it. In this beat, you will normally have a compensatory pause following the PVC. What the patient will feel is not the PVC, but the normal beat after the PVC, because the normal beat after the PVC will be done with a very full heart, a heart that is overly filled because of the pause. In this rhythm strip, you can see where it says normal, a QRS complex, and then that QRS complex is T wave, and then immediately after the T wave, you can see a premature ventricular contraction. PVCs, if they occur on the T wave, may lead to torsade de pointe. This is called the R on T phenomenon. We'll talk about that. Ventricular tachycardia is a very worrisome condition caused by an ectopic focus in the ventricle, a cell that is abnormal that is generating a reentrant rhythm within the ventricle. The heart rate of ventricular tachycardia usually ranges from 100 beats per minute to 250 beats per minute. Usually it's associated with heart attack or ischemia or some type of drug toxicity. Usually the QRS complex is very wide, greater than 0.1 seconds. And the shape is often irregular. Ventricular tachycardia is not consistent with a normal filling pattern of the heart and may be life-threatening. In most cases, people that are in ventricular tachycardia should undergo immediate defibrillation. Patients that are in ventricular tachycardia and do not have a pulse should receive cardiopulmonary resuscitation. Drugs such as lidocaine and amiodarone, as well as beta blockers and procainamide, may be used to treat ventricular tachycardia. The top rhythm strip shows ventricular tachycardia. It's usually a regular, wide tachycardia. On the bottom, you can see normal sinus rhythm following electrocardioversion. Ventricular fibrillation, or VFib, is similar to ventricular tachycardia. However, there is no jagged sawtooth pattern. What you see are irregular, wavy baseline changes to the EKG. In ventricular fibrillation, there is never a pulse. The cardiac output is usually near zero because the ventricle is not contracting. What you see is random activity, no QRS complexes on the EKG. These patients should immediately undergo defibrillation. And patients that have repeat episodes of ventricular fibrillation and ventricular tachycardia should have an automatic internal cardiac defibrillator placed, or an AICD. Here you can see a patient who's in ventricular tachycardia on the left that degenerates into ventricular fibrillation on the right. Torsades de Pointes is a commonly tested polymorphic ventricular tachycardia, meaning that the waves do not all appear the same. And classically, what you see is a sinusoidal increase and decrease, followed by another increase and decrease in the amplitude of the tachycardia QRS complexes. Torsades de Pointes is classically associated with a prolonged QT. The causes of torsades generally include bradycardia, but more likely hypokalemia or low potassium, as well as hypomagnesemia. There are some medications that can also cause a prolonged QT interval. Avinodal reentrant tachycardia, which is a type of supraventricular tachycardia, involves a rapid, regular heart rate with a narrow QRS complex, usually in the 150 to 250 beats per minute range. There are many different types of supraventricular tachycardia, of which avinodal reentrant tachycardia is just one. At this stage, you should be able to recognize that there is a narrow complex, a narrow QRS complex, and therefore the origin of this tachycardia is not in the ventricle but in the atrium. One commonly tested conduction disturbance on USMLE Step 1 is Wolff-Parkinson-White syndrome. Wolff-Parkinson-White involves the presence of an abnormal accessory pathway between the atrium and the ventricles. Normally, the AV node is the gatekeeper between the atrium and the ventricles. However, in some patients, there is what we call a bundle of Kent, or an accessory pathway that the signal can take from the atrium to the ventricles. In these patients, they will have a delta wave. That delta wave represents an early depolarization of the ventricle through the bundle of Kent. The bundle of Kent is not delayed like the AV node by the need for calcium as the upstroke. The bundle of Kent uses sodium as the upstroke, therefore it is much faster. What you'll see in patients with Wolff-Parkinson-White syndrome is a short PR interval because of the delta wave. You'll also see a widened QRS complex. Wolff-Parkinson-White itself does not need to be treated. If you see a delta wave on a patient, you don't have to start any medication. However, if that patient has evidence of tachycardia or instability, those patients should be placed on certain medications in order to slow the heart rate down. Here you can see a 12-lead EKG in a patient with Wolff-Parkinson-White syndrome. You can see every lead shows a delta wave. This is a very commonly tested disease. This concludes our section on electrocardiography. This is also the end of the cardiovascular physiology module. Thank you very much.